Okay, welcome to Chapter 1 of Case Smith. In the OT process of pediatrics, this is just a real quick essential concepts overview. So we're considering pediatrics birth through 21 for the for this class and for general knowledge purposes. So when I say that we need to bring information forward with you, that means that we need to bring information from past semesters, past years, your field periods, other experiences that you've had, and the concepts in these chapters from this book overlap, and you're going to need information from one chapter to bring forward to another chapter. So I mean, all of those things when I say bring information forward with you. So, some of those classes that you should think about include human development, pediatric medical conditions, the last semester, the manual muscle testing and goniometry that you learned, that all applies to pediatrics also. Psych 101, SOCH, abnormal psych, AMP, all of those things will be applied. The knowledge will need to be applied to this semester also. The MBCOT practice analysis, that is what helps to figure out what's going to be on the MBCOT test. And I put that I helped make that because the practice analysis is made up of real OTs from across the United States, and it helps to determine what's actually happening in entry-level practice. And in OT in general, pediatrics is one of the largest areas that we are working in. So some of the philosophy of OT and pediatrics is that we obviously believe that occupation brings meaning to our life, and that occupation can influence health and well-being. So we can do that by providing family-centered care. So when we're working with children, we're not just treating the children. We are assuming that the parent knows best, or that they know their child best at least. And then we're having open communication, mutual trust and respect, and shared decision making. This is a partnership that helps to create effective outcomes. So when a parent feels like they're being more effective, then the child will make more progress. We also use a strength-based focus. So this is not the same as a medical model where we're looking strictly at the deficits. We are identifying and encouraging looking at and using the child's strengths, and we're not ignoring the challenges. We're addressing the challenges, but we start with a strengths-based approach that can help to lead to more self-efficacy and self-determination. For cultural competence, you should look at table 1.2 in the book. We, as OTs, need to acknowledge and incorporate the individual's culture. That means we might need to go out and do a little research if it's not a culture that we are part of. But we need to be aware of the potential differences and respect them, and do what we need to incorporate them into therapy. Therapeutic use of self and building the relationships is super important to get children involved in the therapy and what you want them to do to help them to gain some skills. So sometimes you might hear therapeutic use of self as TUOS, TUOS, just the acronym, but it's a planned use of your personality, your insights, your perceptions and judgments as part of the therapeutic process. So it's not just your bubbly personality being amazing. It's used to encourage, support, motivate, and that helps to build the relationship of trust and safety. There's a specific model that's an intentional relationship model. That's just one way to build that relationship. The process of OT includes theory and clinical reasoning. So you're taking OCC 355 right now, theory, and so you're going to have to kind of pay attention to what's going on in that class and this class at the same time. So here we go. Theory I think of as an umbrella, like the big terms, and then under theory is models of practice and frames of reference. So the models of practice, which are part of theory but kind of under theories, they provide a structure, and then the frames of reference are kind of more specific strategies. So occupational therapists, especially pediatric OTs, have to pay attention to both the developmental theorists and OT specific theorists. So some developmental theorists that we're going to talk about include Vygotsky, Erikson, Maslow, Piaget. You should have heard of some of those along your road here. And then some more OT specific theories or models of practice include sensory integration, motor learning, PEOP, MOHO. So we're going to talk about something called NOBA, not only but also, where you should be looking at the occupation-centered model of practice or theories and a more specific theory if necessary, like sensory integration. So you have to use those theories as a basis to guide your clinical reasoning. And remember, clinical reasoning you're going to get much more in depth with in the chapter on clinical reasoning in the Winnie Dunn book that's on reserve in the library. You can go read that and take notes or do whatever you need to for that chapter soon. So evidence-based practice says that we should be collaborating with and including the client in all aspects of therapy. And that starts right off with the evaluation process, which includes the occupational profile and the analysis of occupational performance. Those are both in the OTPF that you've probably heard those used. All right, the evaluation essential concepts. One, this is where be a detective, look at the big picture comes into play, that there's different ways to kind of start your evaluation process, either top down or bottom up. I would suggest a combined approach. However, you should start with a top-down approach first, which looks at the occupations first. How are they able to participate in the occupations? Then, next, it looks at the client factors, like their range of motion, their strength, those kind of things. So the next thing is you should use multiple methods to evaluate what's going on with the child. Children are frequently complex and not as simple like, oh, you just broke your hip, let me do these specific things. Or you have carpal tunnel, let's do these specific things. They're very frequently a mystery or complex. So we need to use multiple methods to figure out what might be going on. And you should write down the acronym RIOT, RIOT. And that stands for records review, interview, observation, test. And that's kind of the order that you should go in for using multiple methods of information. Those testing can be standardized or non-standardized, and you select those based on the child's reported needs or purpose of the evaluation. Context, you need to look at table 1.3. We're always wondering, what does the environment have to do with the child's performance? How is it influencing their performance? Which means you need to observe them in their natural context. Maybe that's their whole house. Maybe that's the cafeteria at school. We should be looking at the physical barriers, attitude barriers, policy barriers, what's actually impeding their performance. So moving on to intervention essential concepts, we're talking about inclusivity. We believe that all children and people have the right to participate. And with kids, laws like IDEA say they have the right to participate in the least restrictive environment. If you want the child to do anything for you, it needs to be client-centered. It needs to be intrinsically motivated through giving them choices when able. A lot of time that looks very playful. So So if they like it, they will engage in it. And so you need to know, in order to know what is a preferred occupation, you have to actually know the child, which means you need to take time to get to know them, either through talking with them or observing them or talking to people that know them. Occupation can be used as a means, so like to get to a goal, or the occupation might be the goal. You have to give them the just right challenge, means that you have to know what is developmentally appropriate or what is appropriate for their developmental age, then push them just a little further. And it has to be something that can be achieved with your assistance or with help when they're motivated. So this just right challenge, the only way that you know how or what will be the just right challenge is by knowing what is typically developing at that time, what is needed or necessary from the activity through activity analysis, your close observation skills, your therapeutic use of self. These all help you to create the activity and grade it to make sure the child is successful. I was thinking of your adapted toy when I was reading the modify and adapt section here. You could modify the environment, you could modify the task. If you're modifying the task or the environment, it could include assistive technology, and that assistive technology can be something low tech. Some like a highlighter could be a piece of assistive technology for somebody, all the way up to a $15,000 electric wheelchair. So those are things that we are involved with frequently. And then our PICO project made me think of another project that our evidence. Okay, our interventions need to be based in evidence. You should look at box 1.1. That's basically the PICO project's process in a chart. So AOTA also has evidence-based practice guidelines on their website that are great resources. Some more essential concepts for intervention is that we are coaches. We are coaching the people that we're working with on behalf of the children. That helps to expand our reach. Instead of just the half an hour that we have with them or the hour that we have with them, we can expand our reach by consulting and coaching other people. We can use our words and articulate to administrators and policymakers about education and advocating for our clients. Interprofessional teamwork, obviously you're going to work with other professionals and the parents or the caregivers. So including the child, the caregivers, the parents, probably PT, speech, teacher, doctor, psychologist. Those are all people that you might impact or interact with as a pediatric OT. And then our goal is to get our interventions to generalize across environments. That doesn't mean that they can be rock stars in the OT room and then go not be able to do them in other places. We want the students to be able to generalize from the OT room to the classroom to the home to the cafeteria to the grocery store. Real quick, you should go back to interprofessional teamwork, and there's 4 core competencies in the book that you should take a peek at. So you could pause it now and look at those, or you could go back when you read the chapter. There's multiple different ways to provide services to children. Mostly, you've probably seen direct service. This is when the child's seen either individually or in a group with the OT and the student together specifically for direct therapy. The push in versus pull out means that you could push into the classroom. That's for school based. You could push into the classroom and do therapy in their natural environment, or most people, even though it might not be the most effective, pull them out into the therapy room. Consultative models or consultation models, those are indirect services through another service provider. So maybe you're coaching or training the teacher to do something that will benefit the child in the long run. So do you want to do adults or peds? Well, we don't really need to decide yet. OT is amazing because you can treat the lifespan and you can change. I've worked in hospitals, nursing homes, and of course pediatrics. So you don't need to decide yet. And the MBCOT test is throughout the entire lifespan. And I just don't want you to get stuck thinking either I hate children or I love children, because kids are a lot like older adults and they're a lot like people in general. And you'll be working with a lot of adults when you're working with kids. With children, there are a lot more laws like IDEA, the Individuals with Disabilities Education Act, that covers birth through 21, that clearly articulate how certain things have to be done. Funding, there's less insurance involved with pediatrics and more state and federal funding for the services. You do have to know about typical development because they're changing so much and very rapidly. So that's why we're going to memorize our typical development chart and love that and use it a lot. And you get to be super playful, creative, and have fun in your therapy for, I think, anytime you're being an OT, but specifically with pediatrics. So I hope you took notes on that. If you didn't, you can go back and listen to it again and take some notes and make sure you read your chapter. And that's all for today. Have a good day.